Wow. Okay.
Well, welcome to everybody. It is such a treat to see people from all around the country who are saying hi, from San Francisco to Painted Post to North Tonawanda. We are so pleased that our mini medical school is reaching so many people. And it's one of the advantages of Zoom, right? So that's wonderful. I am Dr. Roseanne Berger. I am the director, or we could say dean, why not, of the mini medical school. And I'm pleased to welcome you to this evening's session of joint replacement therapies. I wanted to add a comment on this week. It is Pride Week and all across the country. And I put on orange because today is Orange Day. And if those of you who are interested want to know, tomorrow you should be wearing yellow, Thursday you should be wearing green, Friday blue, Saturday purple, and Sunday pink. So please lend your support as we all do here at UB to celebrate Pride Week and Pride Month. Let me introduce our wonderful experts. You know, one of the things about mini medical school is that we are trying to bring the medical school experience to all of you. And what that entails is introducing some clinical science and the underlying basic science that contributes to providing excellent care. So we have our clinician this evening, Dr. Kathleen Keeley-Boyle. Dr. Boyle is a graduate of the University of Pennsylvania. That's where she got her degree in psychology. She went to the George Washington University for her MD degree, and then joined us here at UB to do her orthopedic residency. And as we are thrilled to report, she remained in Buffalo. And I think it's interesting to note that Dr. Boyle, during her residency, which ended in 2019, she was the recipient of 8 awards during that residency program for her work. So we really are, she's a keeper, and we kept her. So that's wonderful. She enjoys skiing and hiking, and even though she's an orthopedist, it didn't keep her from getting on the slopes. We then will be hearing from Dr. Tony Campagnari. Dr. Campagnari is a distinguished professor here at UB, and again, gracing the walls of our mini medical school, which he has done numerous times. He trained in St. Bonaventure, so he's a local boy. And then did his graduate degrees here at UB. He has published extensively, and will share some of his work with you. And when he has nothing to do, which is rarely, he plays basketball, but is also taking up fly fishing. And last but not least, we have Dr. Mark Ahrensberger. Dr. Ahrensberger is a member of the School of Bioengineering, as well as collaborating with the School of Medicine. So our Dean Payne worked very hard to create a collaboration between the School of Medicine and Bioengineering, because it's just a natural fit, particularly when we're talking about team science. And Dr. Ahrensberger got his degrees, all of them, from bachelor's to master's to his PhD at Syracuse University. So he is an orange man as well, even though he's not wearing his orange pride today. He is a former marathon runner, I understand, but now he's busy taking care of kids. So that's our lineup. I wanted to also put a shout out to our mini-med students. We are a research university, and we just got a call today looking for volunteers who have been fully immunized against COVID-19 and it's been at least a month since your immunizations. where the Department of Emergency Medicine, led by Dr. Brooke Lerner, is looking for volunteers who are willing to do a couple of finger sticks and a nasal swab to evaluate some blood tests that could help identify and treat individuals with COVID-19. If you are interested, the number is here, and we will have these slides put in our on our website, so you could refer to them. So if you're interested and you're an adult, Dr. Lerner will be happy to meet you. So thank you to all of our Mini-Med Advisory Board people who helped design the curriculum for Mini Medical School. And of course, thank you to all of you who are attending, to our speakers, and to those of you who contribute to Mini Medical School, as well as to our sponsors at UBMD. So with that, I will say goodbye and let Dr. Boyle take over. Remember, we do take questions in the chat. I will actually moderate them at the end of the session. And we do have some questions that were submitted in advance. We may not get to all of them, but we will try to get to as many as we can.
All right. Can everyone hear me okay? Dr. Berger, can you hear me okay?
Absolutely.
Okay, and you can see my title slide, correct?
I can.
Fantastic. Okay, if at any point in time you cannot see my slides, or I lag behind, or the volume is not okay, please go ahead and let me know. Thank you everyone for joining us. I see people from all over the country, which is great. I also see Batman has joined us, so thank you, Batman. Very exciting. So I think we have a very nice lineup this evening. My plan is to spend about 15 to 20 minutes here talking about joint replacement. So that is definitely not enough time to talk to everyone about everything about joint replacement, but we've picked just a few kind of overarching topics to discuss that's going to lead more into all three of our passions, which is infection after joint replacement. And then we're going to go into a little bit of the basic science of joint infection, and then some alternative technologies for treatment that don't include currently kind of what I'm doing as a surgeon. And then Dr. Ahrensberger is going to finish up kind of talking a little bit more about applying that technology to advancing different types of orthopedic care in a little bit of some different areas. So we're going to go ahead and get started on the joint replacement aspect. So why do people need joint replacements? So there's lots of reasons. I picked just a couple here, but these are the main reasons why people come to me with pain and looking for a joint replacement. So the main reason why people undergo joint replacements is through osteoarthritis. And we're going to get into a little bit about what exactly is osteoarthritis. Then there's inflammatory arthritis. There's different types. So these are people that have rheumatoid arthritis, psoriatic, and even other types of arthritis. Post-traumatic arthritis can happen when people have fractures around their hip joints or their knee joints. And I apologize. I should have prefaced this by saying I am a hip and knee replacement surgeon. I only do hips and knees. I know there are some people that may be interested in some questions about shoulders and ankles, but I'm going to have to give those people that are interested in those things the names and numbers of my colleagues to answer those questions for you. So we're going to just be talking about hips and knees today. So post-traumatic arthritis, it can happen around the knee or the hip. You can fracture any of those bones around there. You can have ligamentous injuries to there, cartilage damage to there, which can cause a whole cascade of events that leads to arthritis, again, which we're going to talk about in a slide or two. Then you can also have post-infection arthritis, which is called septic arthritis. There are babies that can get this, that can lead to cartilage damage, which again leads to arthritis when people present to my office. So what is arthritis? So the image on your left, if you're facing the screen, is a normal appearing hip socket. The one on the right is one that is very arthritic. And this is a schematic. We're going to look at some x-rays as well. So arthritis is, in the traditional sense, is a loss of cartilage. So in that image on your left, you can see all of the white is actually articular cartilage. So that is cartilage that is attached to the bone on the thigh bone side, which is the femur, and then also on the socket side, which is called the acetabulum. That is the cartilage that we are talking about when we talk about arthritis or loss of cartilage. There are other types of cartilage in the knee and the hip. Many people are familiar with the meniscus of the knee. That's also a type of cartilage, and that can become torn, sometimes repaired by my sports partners, or sometimes debrided or chopped out a little bit by my sports partners. But really, arthritis is this sense of this articular cartilage, or the cartilage that's covering the ends of the bone, that becomes lost. Then you get a loss of the lubrication of the joint. We all have a very nice lubrication of our joints usually. And then as that cartilage wears away, the joint space becomes narrowed. You can see in that picture on the right that that space that was there before isn't really there anymore. And then you become bone on bone. So you hear a lot of doctors say, or maybe your friends have had a joint replacement and they said, the surgeon told me I was bone on bone. So that basically means that you have lost that, again, that white articular cartilage in the joint. And now you have bone that's against bone where it's not supposed to be there. And that causes a significant amount of pain for most people. That generates a lot of pain receptors. And that's why a lot of people have such severe pain when they come to see me, is really that bone on bone. Bone spurs are kind of a secondary part of arthritis, and you can see them there on the right. These occur when you have abnormal forces that are going through the joint. So you've lost the cartilage, you've lost the space, you've lost the lubrication, and now you have all these abnormal forces that cause more bone to form through kind of basic physics. And that's what bone spurs are, is it's trying to form more bone to create more surface area because it's seeing more force on the joint. So that's kind of what those are. And they can also cause pain because they can cause impingement where, the joint will kind of hit that bone spur, and that can cause pain as well. So what are the risk factors for arthritis? So there's a lot, and then there's a lot that we still really don't know. So some of these are more of a speculative, some of these have really good literature behind them, but in general, these are some of the big categories that we look at. There's lots of books, like you see the one on your right there, about what you can eat to help with your arthritis, to prevent arthritis. And basically what it all boils down to is anti-inflammatory life. So anti-inflammatory diet, anti-inflammatory, things that you can do as far as exercise to decrease the inflammation in your joints. And then there's all these other things. So occupation is one. So I do have a lot of patients that either were NHL hockey players and they're coming to me now because of their hips, or they were in construction for a long time and they were lifting, heavy things. So it's kind of this repetitive loading motion. But on top of that, if your muscles are weak, you have a large body mass, and now you're loading your hips and knees, that causes abnormal forces on the joint, which causes the cartilage to basically disintegrate, or it can tear and then disintegrate. Metabolic syndrome is basically a term for people that have a couple different types of medical comorbidities, all lumped into one, that create they create an inflammatory response in the body, which people think may contribute to arthritis. Increased age, as we know, I have patients in their 70s, 80s, and 90s. And I do have patients in their 30s, but it's much more common for me to do a joint replacement on somebody in their 60s, 70s, 80s, and 90s than it is for me to do a 30-year-old. And so that's just kind of the nature of a little bit of the wear and tear that you hear about. Ethnicity, we found there's certain origins where people are known to have more arthritis and earlier on than people that don't have as much arthritis in certain countries. So ethnicity plays a part into it. Genetics, we found over time, is playing a part more and more into arthritis. This is all a huge area of research. We don't know everything yet, but vitamin D receptors, estrogen receptors, and all the inflammatory cytokines have been linked to arthritis. So when is it time for a joint replacement? All I can say is pain. So pain. So if you have an X-ray, if someone came into my office and they have an X-ray that shows that they have arthritis, but they're like, "Doc, I don't have any pain," I'm not going to be doing a joint replacement. So it's pain. And then what I mean by loss of function is that as the joint becomes worn down, people can get a lot of instability. And they say to me, my leg gives out on me. A lot of that has to do with the fact that you've lost the cartilage and you've lost a lot of the things in the joint that usually keep it very stable. So then people go from not using an assistive device to maybe using a cane or even maybe a walker. So that's an extreme example of loss of function, but I see that in my office. Then there's the larger category. People are unable to do the things that they enjoy, whatever it may be. Tennis, walking the dog, walking with your partner, just going for a stroll, cooking dinner, standing up and cooking dinner for an hour. So all these things become harder and harder to do if the arthritis becomes so far progressed. And then people do have to come to my office with x-rays that are consistent with arthritis, and I'm going to show you some of those. And then also, very importantly, they are stopped responding to non-operative treatments. The purpose of this talk is not to go over all the non-operative treatments, but in general, it is anti-inflammatories, the diet that we kind of talked about. So an anti-inflammatory diet, but also anti-inflammatory medications, Advil, Aleve, things in that category, Celebrex. And then watching your weight, keeping your weight in check in both ways. So overweight, keeping it in check by losing weight. If people are underweight, keeping it in check by staying very well nourished and protecting those bones and the cartilage. And then also modifying your activities. And then physical therapy, which is plus minus for me specifically. Sometimes with people with very arthritic joints, physical therapy tends to aggravate it a little bit. But all of my patients are a little bit different. So I take physical therapy on a visit by visit basis. And then you jump into the more invasive things like injections. There's all different types of injections. And there's things like stem cells, which are not very well published in the literature. There's not a lot of science behind stem cells yet, so we have to be a little careful there. But there are proven injections, and then bracing. So those are kind of, and icing and things like that. But those are kind of the big categories of non-operative treatments. So when my patients have failed all of those, then I move on to talking about a joint replacement, but kind of only when they've failed all of those measures. So we're going to start with the hip. The image on your left is a normal hip x-ray. So there's two hips on that x-ray. So the top of your screen is the lower back or your lumbar spine. And then you have your two big wings there. That's your iliac wings. Those are part of, so you kind of have two pieces to your pelvis. Those are the two pieces to your pelvis. And then you have your two hips. So that's the ball and socket joint. And there is space there. And then when you look at the image on your right, you can see how different those two images are. The image on your right shows complete loss of space. Kind of the ball is not really located in the socket anymore. It's getting pushed out of the socket. That's because bone is growing inside the socket. That's that bone spur I was telling you about. They can actually grow inside the socket. And then this one hip actually looks like it's almost got like a beard on the bottom of it. That's just a big bone spur. So the hips on the right are severely arthritic. They've got cysts and no cartilage left, bone spurs, and they're not really in the right location that they should be compared to the one on the left. This is a knee x-ray. This is a left knee. The image on your left shows really nice space between the femur and the tibia. Your femur is your thigh bone, the tibia is your shin bone. And it does not show really any significant bone spurs or anything like that. Then we go to the image on the right, and you see, this is kind of I would say, the most normal appearing x-ray when someone comes in my office, is they've lost all of the cartilage on the inside of the knee. So that's called the medial part. But that does not mean they don't have arthritis in the other parts of the knee. This is just one view. So then what are joint replacements made out of? So we're going to start with a total hip. These are all pictures of some different companies. There's lots of different companies out there, and every company makes a different geometry of an implant. So the images on your left are stems that go inside the bone, inside the thigh bone. And some are used in first-time joint replacement. And then one of these pictures is actually a big stem that's used in redo joint replacement. And then the other images are actually the sockets. And the very colorful things that you see here, the pink, kind of the peach color, and then the bright metal and the black are all different types of heads to replace the ball that you're taking out. So the stem and the cups are usually made out of titanium, and the liners are usually made out of polyethylene, which is that white liner that you see with the cutout of the metal cup there. And then the heads can be cobalt chrome, ceramic, or oxinium, which is made by one company. Knee replacements are a little bit similar. These are all different pictures of different types of knee replacements. The top one is uncemented, meaning that we don't use any type of cement, which could be considered a type of glue. to put the implant into your bone. That is an uncemented implant, and it's on the back of it. You can see kind of a rough edge that's actually 3D coated or 3D printed. And the way that they make this is with a very specialized roughened surface. So if you undergo a knee replacement, your bone visualizes the undersurface or the back surface of these implants as bone, and it wants to grow into it. So that's called osteointegration, which Dr. Ahrensberger is going to talk a little bit later about some other things. But the bone unitizes itself with the implant. That also happens in hip replacements with the stem and the cup as well. And there's different types of coatings for hip replacements that enhance that ingrowth, we call it. Then on the bottom of your screen, you're going to see an implant to your left that is a cemented implant that we actually utilize cement to fix the implant to the bone. And then at the very bottom to your right, that is a partial knee replacement, which is also cemented. And the backs of those implants are much different than the backs of the implants of uncemented implants. That comes a little bit into play when we're going to talk a little bit more in the lecture series here. So some frequently asked questions, these are kind of like the top 5 questions that I get in my office is, okay, doc, how long do they last? So these are very generalized numbers. You may hear from lots of different people, different numbers. We have new implants that were created about a decade ago-ish. And then we have new plastic, which is about 15 years out. So with the new implants that we're using, we don't have 20-year data on them. So these are all projected numbers. But in general, for total knees, 90% are functioning at 20 plus years, okay? So that means that those people didn't have to have those implants taken out at 20 years. Hips are a little bit better, 90% functioning at 20 to 25 years. And again, those numbers in 10, 20 years from now may look way better than this. We may be getting 30 plus years out of the implants we're putting in nowadays. So what improvements have been made? I talked about the implant design. Tons of implant design improvements have been made for the better. Instruments, the instruments that I use now are not what my mentors used. They're meant for a more soft tissue preserving surgery. They have bends on them and curves to allow you to get in through a smaller incision. Smaller incision isn't always better, but that's kind of the way that we're moving in joint replacement. Robotics, computer navigation, I use both. Lots of my partners use both, and it's a wonderful way to improve your accuracy of how to put the joint replacement in. Now, as a joint replacement surgeon, you have to know how you want to put the joint in to put it in, quote unquote, accurately. So I think that's where some of the art of joint replacement comes. So when people ask me if I use robotics, yes, I do, but I have to have the proper plan in place to utilize those robotics to make sure I achieve that plan. And then what ages can someone have a joint replacement? I operate on people. I mean, I've done a 19-year-old all the way up until today. I had a wonderful lady who was 94. So I think it's not, can you have it? There's just complications and concerns you have to talk about with the patient. So, and their medical history and what medical problems people have. So it's not, I can't have one because I'm 45, or no, I can't have one because I'm 90. There's people on either side of that. It's not as common. You've got to take each person, on their own and evaluate them, whether they're ready for one and they're safe to go through with one. How long is recovery? Recovery is about 3 months. You will hear from different people, all different things. In general, my patients are about 90%, 95% recovered at 3 months. People go back to work at about 6 weeks. Again, this is all very variable. And now the last part, which is what I'm going to talk about, is what at the end of my conversation is going to be what complications can occur. The number one thing I worry about is infection after joint replacement. And then plastic wear, which is all that white plastic I showed you earlier. The implants can loosen, they can break. People can break around the implants if you fall, and then medical complications. So those are the things that the anesthesiologist will talk to you about, which is, stroke and blood clots and things like that. So infection after joint replacement. This is the leading cause of revision or redo surgery. It is the number one thing that I worry about. about 0.5% to 2% of patients become infected after total joint replacement. It's a little more common for knees than hips, but in general, it's about 0.5% to 2%. We're like, well, am I the 2% person or am I a 0.5% person? All depends on your medical history. If you smoke, lots of different things play into that infection risk, which I would talk to that person about in the surgery. Before the surgery. And then the interesting thing that what people don't realize about infection, which is going to be the really interesting part of this lecture series, is what my colleagues have to talk about. But it is not take an antibiotic and, go back to work. This is, you got to go back to the operating room, and 90% of the time, it's multiple times back to the operating room. It's not just one operation. These things require sometimes multiple washouts, which we call an IND, which is irrigation and debridement. Or you got to take all the implants out and you have to put a spacer in filled with antibiotics, and then get antibiotics for a long time. And then once the infection's cleared, we put a new knee or hip back in. It's a big, big deal. So in general, the three things that I do when looking at, and again, there's people that have been operated on many times and have had multiple infections, but in general, we got three options. One of which is you can wash out the knee or the hip and leave all the implants in place. The success rate of that is about 50% right now, plus minus. Option number two, we can remove all the implants, do a washout, and put new ones in the same surgery. And then the last option is you take out all the implants, you do a washout, and then you fill the joint with an antibiotic cement spacer. And I'll show you some pictures of those. So that's kind of what we're going to focus on, because that technically is the gold standard in our country right now. So this is a little schematic talking about what we call a two-stage exchange, or which is remove implants, wash it out, put in a cement spacer, give IV antibiotics, wait a couple weeks, put a new hip back in or a new knee back in once the infection's cleared. So what the schematic is trying to show you is all those red dots on your left, which says bacteria, they actually find their way to the metal implant and they attach themselves to it. All right, that's called biofilm. And then what we need to do, we don't have anything currently, which Dr. Ansberger is going to get to, but in my world at the moment, to just kind of get that bacteria off the implant, I have to take these implants out of people's body to get the bacteria out. And then I do a washout to get the soft tissues clean. And then we give IV antibiotics to, again, get rid of the bacteria that are lingering around. Then we put in a cement spacer, which is that center picture, which is the white. So that's all cement, no metal. And it's got antibiotics in it that just keep kind of giving out antibiotics into the bone and the soft tissues for a couple weeks. And then the last stage is stage 2. That's just a schematic of us putting a new hip replacement back in. So these are images of spacers, we call them. So the image on your left is a spacer. That's an antibiotic filled spacer. And all those wires that you see, I had to put those on there because I actually had to crack this patient's bone open to get this titanium stem out. And that's very common. And then there's another type of spacer on your right here, which you can see there's no head. That's called a static spacer, but that's often a choice, is that we just leave kind of a ball of cement in there and we put cement down the center of the femur and we kind of let that hip sit like that for about 3 months. These are some pictures of some knees. The one on the left is a spacer again. Those wires that are going down the center of the tibia and the femur actually are coated in antibiotics to treat any infection that's inside the bone. And then the images on your right, again, is that static spacer. So that's basically someone that has a whole bunch of cement in there and they're not allowed to bend their knee or really walk on this for 3 months. So it's quite debilitating. So again, to reiterate, what are the problems with infection after joint replacement? Extensive surgery, multiple surgeries, long-term antibiotics, complications from antibiotics, long hospital stays upwards of over a week plus in the hospital, limited function. I don't let my patients put a lot of weight on these spacers. It's not like you're walking around, you're doing a lot of kind of not doing a whole lot of things. Higher complications, stroke is higher, blood clots are higher, all sorts of complications from the antibiotics, and it is extremely costly. It's about $150,000 to $250,000 to treat one of these infections. So why are these so difficult to treat? As I talked about, the bacteria, they actually kind of attach themselves to the biomaterial, meaning the implants. We can't eliminate this bacteria without removing the implant currently. So we've got to take the implant out to get rid of the bacteria. These patients have an extremely high resistance to antibiotics. That's due to kind of a very complicated network that these bacteria like to do. And they actually kind of like go in hiding for a little bit, and then the bacteria can't really, the antibiotics can't really get to them. And then there's the formation of a biofilm, which leads me to kind of our next speaker, who's going to talk to you a lot about the basic science behind biofilms. So Dr. Campaneri, I am going to stop sharing. Oh, you guys can see that? Dr. Berger, can you see the new one?
Yes, I can. Bacterial biofilms.
I'm going to mute myself then.
Me unmute.
Yeah.
Hold on 1 second. Okay.
Yes, we could hear you now.
Okay, good. Thank you, Dr. Boyle. That was absolutely wonderful, and it really gave me a nice lead in, and I also learned a whole bunch of stuff, as I always do when I get to talk to you guys. Okay, so I couldn't share my screen. So I think Jennifer is sharing it. So you guys can see all this, I'm hoping. Okay, so let me just
Yes,
talk to
we
you
can.
about the difference between simple floating organisms versus biofilm. So most labs, when they study organisms, yeah, Jen, go ahead and put them all up, because this way we won't have to do this in slow motion. Good. Okay, go back one. So most laboratories, for the last 30 years of my life, we were studying free-floating organisms, and most people do. So these organisms are called planktonic bacteria. And biofilm bacteria are really organisms that become attached to a surface, and they, excuse me, they really came to play a long, long time ago. It's just no one recognized these as problems because they just didn't study them. They really were focused on these free-floating organisms. So the neat thing about these organisms, now that everybody's jumped on the bandwagon over the last, 20 years or more, they know these organisms in a biofilm are completely different than these planktonic freely floating organisms out there. They actually can communicate with each other. It's called quorum sensing, but that's a fancy word for they can actually talk to each other. And they tell each other to actually turn on and off different genes. And I'll tell you where that becomes important. But it's fascinating to study this. And there's some organisms can actually communicate with other organisms. And you can really, this is quite a complex area. Now, the neat thing about this is because they can communicate, it gives them a tremendous survival advantage, mainly from attacks by your immune system and also by drug treatment, antibiotics. And so, although planktonic bacteria can really cause disease, it's widely accepted now that many bacterial diseases in humans results from biofilms, and especially chronic long-term infections or repeated infections. Go ahead, Jen. Yeah, go ahead. You might as well get through it all. Thank you. Okay. So why are biofilms a major source? So they first start out by being very small colonies with only a few organisms. So they'll seed, say, your nasal pharynx. They get in your nose and they seed your nose. And they are, in the beginning, they're undetected. Then they begin to adhere and they begin to start communicating. They expand and grow somewhat, but they grow slower. And what they do is they start to form something called an extracellular polymatrix, or it's just a big protective coating. And it's fascinating because it can be made up of dead material from the bacteria, or it also can be made up of human material, especially human DNA, cellular debris. They just start to pile this up on top of themselves. And what's really neat is they can survive in all kinds of microenvironments. So this is why people began to notice them. So inanimate objects like doorknobs, faucets, sinks, gloves, masks, toys. So let me tell you just a fast side story. We were actually called in to look at a daycare center it was about 6 or 7 years ago. And I don't want to mention any names, but we went in there and took stuffed animals and toys at the end of the day after they were cleaned and disinfected, and we could actually grow organisms off them because they were in there in biofilms. So they're very resilient. They're really resilient to cleaning solutions, the host immune response, and they're often 500 to 1,000 times more resistant to antibiotics. And the next line there, the reason is most antibiotics actually work on organisms that are actively growing because they interfere with cellular replication, they interfere with the cell wall, they interfere with the mechanisms of the organisms replicating and growing. Biofilms are, for lack of a better term, dormant. They're alive and they can communicate, but they don't actively grow. And because of the resistance, the biofilms are now serve as reservoirs. They're the leading cause of infections. They're nosocomial infections in hospitals, a leading cause of infections in the community and in the human body. So you can imagine if you have a source like one of the things we study is middle ear disease in children, otitis media. These kids, they have biofilms in their middle ear. You just can't get rid of them. Go ahead, Jen. Okay. So here's the steps involved. Yeah, just put them all up. Okay. Oop. Okay. So I have a cartoon there, and then I have actual SEM pictures below that. And then after below that, that is fluorescent confocal microscopy, all of cells that begin. So the first one is they adhere to the surface, and that's that little area where you see them clumping. But below it, you can see a few organisms. And then the confocal is it's just a fancy microscopic method to look at them through a plane. So as they're growing, this is on a surface and they're attaching. And these organisms have been labeled with a fluorescent dye so you can see them. Then there's growth and extracellular polysaccharide that starts to form. And on the second set there, you'll see you'll see those little dark areas around the organisms. Those are actually extracellular matrix starting to form. And then in the confocal, you see how it's getting denser. They mature and they expand. So you can see that in the cartoon, that yellowish substance is the extracellular matrix. You can see how well they've began to expand below that. And then you can see in the green picture, there's depth there, right? So now it's getting thicker. And then there's active dispersion or death is the last one. Now, one of the things that's really important is they can signal each other when it's time to disperse. And there's a lot of studies on this. It's a fascinating area because people just thought they got so big that they just broke off and they floated away or they all died. But they can actually communicate when they want to disseminate. And so those again become the planktonic ones, those little ones on top swimming there. There you go. And those actually are, again, metabolically active organisms that would be more susceptible to antibiotics than the ones in the group. And you can see the bottom of that green, how thick that picture got of this actual growing biofilm. Go ahead, Jen. Okay, so here's this is actually on orthopedic implant material that we started working on with Dr. Ahrensberger years ago. And we used titanium. And what you're seeing there is the 1 hour, you can see the organisms have began to attach. And when you zoom in on them, you can see at the screen below them, where you can see how they are, those little attachments with those little threads in between them, how they're starting to really glom onto each other. In the 4 hour picture, you can see that they're starting to grow and build. And if you look at that picture below, what I want you to start to appreciate is what Dr. Boyle had brought up. When these organisms begin to glue themselves together like that, you can see all those attachments. You can begin to feel how difficult it would be to get this thing off, no matter what it's on. So go to the next one, Jen, please. That's 8 hours and 24 hours. So in 8 hours, you can see that they're really growing very nicely. They are beginning to form these little pores. And now you can see the extracellular matrix like a glue that's being stretched out in these organisms. And if you look up at the 24-hour one, that's a high view. And what those areas where there's no organisms, those are water channels and channels where they can get nutrients to each other. And then when you look below it, you can see they're completely covered with this dense, thick, gluey substance. And you can, again, appreciate how difficult these organisms would be, not just because they're stuck together, but also, you'll see in the next slide, the depth of this is really important. So go ahead, Jen. So this is now an SEM coming in from a side view. And what you're looking at now is the 24-hour growth. On the left, you can see the height. There's the open channel in there. And the height of this thing is about 100 to 150 microns. And the next slide, or right there, the next picture there, look how close, when you look at this is a very high magnification on titanium. And you can see they've put roots in, if you will. And we actually for years tried to figure out what those are, and we never did. And to this day, we still don't know what those are. But you can see how they can get onto a surface and hang on for dear life. And then when they expand. So I think, click one more, Jen, see if there's yeah. So if you look at that, that's about 100, 150 microns thick, which comes out to 10 to the 8th bacteria per ml. So that is an enormous load of organism. And so you can see that once these biofilms get on to an orthopedic implant, they're virtually impossible to get off unless you go in there, like Dr. Boyle so nicely described, and get them off. And that, even that's a real problem, because they could by that time spread to the bone and they could be all over the place. It's really quite a challenge. Go ahead, Jen. So here's the magnitude just in the medical device world, right? So central venous catheters, prosthetic heart valves, urinary catheters are an enormous problem. Artificial voice prosthesis, intrauterine devices, but of course, artificial hip, this also would cover knees, elbows, whatever. It actually, dental implants fit into that category. So it's an enormous problem all over the place, especially with indwelling devices, no matter where you are. It also has fallen into the food industry. So, it's clogged up. I mean, I could tell you the number of companies that well, let me go to the next slide and I'll tell you a little story. Okay, so how did we get there? This is kind of a neat story. We started, we decided in 2010, don't go anymore, Jen, hang on a second. Dr. Ahrensberger showed up at my door on the South Campus, and he asked if he could talk to me, and I said, sure. And he said he had this great idea, and he's an expert at electrical engineering and materials and orthopedics. And I said, you have the wrong guy. I mean, I don't work on anything like that. In fact, I think I got a D in physics, and I really hate this kind of stuff. And he said, no, but do you work on biofilms? And I said, I do. And he said, well, biofilms are a big problem in orthopedics and in implants. And of course, at the time, my close colleague, Tom Russo, who I'm sure many of you have seen on TV, the chief of infectious disease, was my next door neighbor and my good friend. So I've had a lot of exposure to clinical infectious diseases. And of course, Tom had told me the challenge of orthopedic implants when they become infected. So I was a little fascinated by this. And he proceeded to tell me a story as to he thought he maybe would have a method that could possibly get these things off implants without having to take them out. And I think Dr. Boyle made a great point of showing you how challenging these things are and then what you have to do to get these things out. So this clearly would be something that would revolutionize the way things are going. And it turned out that, you can't teach an old dog new tricks. Well, actually it can, because he taught me new tricks. Well, we went off on this tangent where we decided we're going to try and figure this out. So Jen, just click the next couple. So here's where we started. I want to just appreciate two more. Good, right there. So here's the way we started, right? We didn't have money to begin with. So what you're looking at is our version of this very clever technology we were going to develop. And it went from, a couple of glass chambers and the next picture over has different tapes. we put them in tip boxes. We did, the next one is actually a styrofoam container we cut the hole out of so that we could put all these things in there, get all the electrodes and everything we needed. And then the bottom one just shows duct tape because everybody uses duct tape in this world. And I thought we really, and these are actual photographs. I'm sure Mark remembers these very well. These are actual things we started with in the lab. In fact, the very first experiment we did worked like an absolute charm. I mean, it was staggering. We were stunned. We just put that, it's on the top left there is what it looked like. And all that is these electrodes with bacteria in there. And we turned this current on and we came back in the morning and everything was dead. And we thought, wow, unbelievable. And then we realized we didn't set up an experiment without the current flowing. And as my good friends would say, nothing ruins a good experiment like a solid control. So we tried this without any, we set it up again. And when we came in the morning, both of the things were dead, even the one without current. And then I started learning more about metals from my good friend, Dr. Ahrensberger, who's a metal expert. And it turned out we had a silver nitrate or silver chloride, I believe was one of the electrodes. And that's very good at killing organisms. And I think what really the neat thing about it is, and what I want you to get from the end of this story is, we've gone a long way and he'll show you how well things have gone. But I think what's really important is also being able to have clinicians like Dr. Boyle who are here that really have an interest in moving the field forward from a research standpoint, as well as, getting into clinical translational studies. And then that fits very nicely with the infectious disease background I have and the lack of expertise in anything related to physics or electrics, and Mark's skill set is completely different than mine. Yet we've been able to really spend a lot of time making great progress, and he'll show you that next. And it really is a neat team effort from a clinical standpoint and also a basic science standpoint. And with that, I'll turn it over to my good colleague, Dr. Ahrensberger.
Okay, thank you, Dr. Campieri and Dr. Boyle, for setting the stage for my talk here. I'll just call up my shared screen. Okay. Well, good evening, everyone. And I'll continue tonight's presentation by looking at some novel technology, as Dr. Campieri alluded to, that we're developing to treat implant-associated infections. So the first thing is going to be that I have some disclosures. I'm a co-inventor of a patent that is exclusively licensed to Garwood Medical Devices for commercialization, and we'll see that in a slide or two here. I'm also on the scientific advisory board for Garwood Medical Devices, and we've received grant funding from Garwood and a couple of other orthopedic implant companies. So as we've already heard in tonight's talk, that periprosthetic joint infection is a devastating complication, and it has a projected increasing clinical burden, and that definitive treatment remains a challenge, and that there's relatively high rates of recurrent infections. And as Dr. Campieri brought out, and as Dr. Boyle mentioned as well, that it's thought that this is due to biofilm formation on the implant surfaces, which makes these infections very difficult to clear without removing the implant and putting in a new device. So it's clear from this background here that there is a need for new strategies that are going to prevent and or eradicate these types of infections. So we have proposed as a potential solution to utilize the metallic implant itself as an electrode and deliver through local delivery something that we call cathodic voltage controlled electrical stimulation, or CVCES for short. And the intention here is to use this stimulation to promote three biological processes. The first is to eradicate the implant-associated infection. Importantly, as we've mentioned, without having to remove the implant. This would allow for implant retention and maintenance of biomechanical stability and enhance patient mobility. The second application is to prophylactically apply the stimulation to the implant. This could be done either during the primary procedure or perhaps at periodic post-op intervals to prevent infections from establishing on these implant surfaces in the first place. And the third biological process that we are hoping to control is to use the stimulation to promote bone formation around the implant or to enhance, as Dr. Boyle had mentioned, the idea of cementless fixation or osseointegration, bony ingrowth to provide the stability of the implant. And we envision a range of clinical applications for this infection control strategy. As we see here, this can span from non-invasive applications where there are percutaneous exposures or the implant is sticking through the skin that would allow for direct electrical connection. Applications here or examples are osseointegrated prosthetic limbs, and this is a new type of prosthetic limb where there's a titanium implant that is anchored into the remaining bone stock of the residual limb. And then there's a percutaneous or through the skin connection that's made to the external artificial limb. This approach would also be applicable, as Dr. Camilleri had mentioned, dental implants, as well as external fixation pins, which are used sometimes in fracture care. So those all are percutaneous devices. There's also minimally invasive scenarios in which a transcutaneous electrical connection, so the connection is transcutaneous now, is made between an external stimulation device and the implant that is fully contained within the body. And it's this scenario here that really is most applicable for treating infections associated with joint replacements or other types of orthopedic hardware, such as trauma hardware or spine implants that are permanently implanted in the body. And finally, there's the situation there on the right, where a fully implantable sense and response stimulation system could be advantageous. Now, this system here is it would require more advanced development and is a further bit down the road. But notably, we have entered into this commercialization partnership with Garwood Medical Devices. They are a Buffalo, New York-based startup company to bring this stimulation technology to market. And their first goal or first focus is on the minimally invasive application through their system, what they call BioPrax. And I have a very brief video here just illustrating that.
The BioPrax device is a new minimally invasive technology that is under evaluation for the treatment of biofilm infections without removing the implant. Garwood BioPrax has 2 electrodes that are affixed to the patient's skin. A needle is inserted, making physical contact with the implant. Low voltage treatment is used to generate an electrochemical reaction at the surface of the implant, promoting bacterial destruction on the entire surface.
And so Garwood is gaining momentum in many different aspects, including the regulatory path, product development, as well as expanding their facilities and personnel here in Buffalo. And it's also a point of pride for me that 2 of my former graduate students are actually working there at the company, and they're actively part of translating some of our academic research into this potential marketable product. Okay, so now that I've kind of given you the high-level vision, if you will, of the technology, I'd like to pivot just a little bit to talk about some of the underlying science behind the technology and provide a couple of snapshots of the research that we're doing to further optimize the therapy. So in our group, we've adopted an electrochemical perspective of the bacteria implant interface. So our initial focus has been on titanium implants, but it's important to recognize too, as Dr. Boyle had mentioned, there are other types of materials and metals that are used, and we believe this approach is largely applicable to the other metals that are used in orthopedics, such as stainless steel and cobalt chrome. So in this electrochemical perspective, there are really 2 general categories of electrochemical interactions for us to consider. The first category is non-Faradaic or charge-charge interactions. So some of the factors to consider here include that the titanium surface charge is voltage dependent, that most bacteria have a negative surface charge, and that in addition, that biofilm matrix that Dr. Campigneri described, it can be made up of charged species as well. And also important to consider that many antibiotics are charged molecules. So we can begin to see how there's some fundamental charge-charge interactions that could take place. The second category is Faradaic or charge transfer interactions. The factors to consider here include that the type and the rate of the charge transfer reactions at the titanium surface are voltage dependent. And of specific relevance, is that the dominant, what we'll refer to as, I'll explain a little bit later, the dominant cathodic half-cell reactions in most biological environments result in local oxygen depletion, reactive oxygen species generation, and increases in the pH in the microenvironment adjacent to the electrode. So as you can see from this very short summary, there are some fundamental bacteria material interactions that have an electrochemical basis. And therefore, our overarching objective of the work was to utilize, again, this type of stimulation called cathodic voltage-controlled electrical stimulation to modulate those voltage-dependent interactions or titanium surface properties, and use that to eradicate and prevent implant-associated infections without removing the implant. So I'm going to try to make this as kind of an overview as possible, but I think there's some key terms that I want everyone to kind of have as we go forward into a couple of slides down the road. So I just want to spend one slide describing the cathodic polarization behavior of titanium. So what you see here is a polarization plot of the applied voltage versus the current density that's on a log scale. The first characteristic feature of the plot is that the potential where the current dives down to very low values, you can think of it as essentially zero current. This is called the open circuit potential or the resting potential. Now, conceptually, you can think of this as the equilibrium potential of a titanium implant if you're not doing anything to control it. It's just sitting there. This is the potential that it would measure. When you are at a potential that is actively being controlled and you're driving that potential to values lower or below the open circuit potential, this is referred to as that cathodic polarization. So that's where that cathodic voltage comes from in our title. And the cathodic polarization is applied, and these potentials are referred to as cathodic potentials, and the currents that are associated with those are referred to as cathodic currents. Now, what does that mean? That means that electrons are being delivered to or shuttled to the electrode, and we're forcing reduction reactions to occur at the metal electrode interface. And it's also important to note that the current in these plots here indicate the rate of the reduction reaction. Okay, so when the metal begins to become cathodically polarized away from the open circuit, the current begins to increase and follow the kinetics of this first reaction, which is the oxygen reduction reaction. And so you can see in this cartoon here that this reaction results in a localized decreased oxygen tension or consumption of oxygen and an increase in pH. And as the current keeps increasing with voltage until the fusion of oxygen begins to limit the rate, and we kind of get this vertical line behavior of the plot. And then eventually, as you keep going lower in potential, it's forced to greater cathodic potentials. The water reduction reaction kicks in. It's a different reduction reaction, but we can see that one of the end results of this also is that it is increasing the local pH. Okay. So to kind of summarize a bunch of work, we've performed a large number of studies going back 10 plus years with Dr. Campagneri here that show CVCS has potent antimicrobial effects. And for those studies that we've done, we've evaluated the effects of -1 volt, -1.5 volts, and -1.8 volts, because as you can see on this plot, they represent transitions in the polarization behavior of titanium. And we also performed infection eradication studies and infection prevention studies. These were done both on the benchtop as well as in animals. And we performed these experiments utilizing or evaluating this against a broad spectrum of human pathogens, as I mentioned here, for a range of stimulation durations in the presence and absence of antibiotics. And so obviously I don't have time to go into all of those studies, but what I want to do is just provide a couple of quick snapshots. So in one series of studies, we utilized a rodent shoulder implant infection model in which a titanium implant is placed through the humeral head and then extends out the lateral cortex of the Long Evans rats. The implantation site was inoculated with a bacterial of about 10 to the 5 colony-forming units of a clinical isolate of MRSA, which is a problematic bacteria, and a local infection was established over the next 6 days. And we utilized this model to conduct several studies, And perhaps the most clinically relevant, I'll just quickly go through the outline here. In this study, there were 3 test groups, a no treatment control group, a drug-only treatment group, and a combo group that received the drug and the electrical stimulation. These animals were implanted and inoculated on day 0, and on day 6, the animals that were in the treatment groups, they began to receive their twice daily dosing of vancomycin therapy. And on day 7, the combo group received the minus 1.8 volts for 1 hour, and the drug treatment group received a sham procedure. Essentially, it was maintained at the open circuit potential. And then these animals were continued on with their twice daily dosing until the end of the study on day 42, when we harvested the implant and the bone tissue for evaluation of bacterial burdens as well as histology analysis. So the results here showed that prolonged vancomycin therapy, so just giving drugs alone, reduces the bacterial burden on the implant and the bone tissue. However, there was still a relatively large bacterial burden that was present, and we felt that if this was left untreated, this would likely give rise to recurrent infections, much like that what we see clinically with recurrent PGI infections. However, when the single 1-hour CVCS treatment at minus 1.8 volts was combined with this drug therapy, there was further reductions in the bacterial burden on the implant and on the bone tissue. And importantly, there was no bacteria enumerated or counted in 80% of the animals. And we felt this was a strong indicator that the infection had been eradicated from the implant and the bone tissue. And furthermore, when we looked at the tissue sections, this was done by a pathologist that was blinded to the study. It revealed that the stimulation had no histologically discernible deleterious effects on the surrounding bone tissue. The hallmark of each section, as you see here, was this central implant defect surrounded by a layer of granulation tissue. And that layer was most robust in the no treatment group and was thinnest in the combo group, which seemed to be indicative of the resolving infection. So that previous histological analysis, we had removed the implant prior to looking at the tissue. So we really were interested, though, in understanding how does CVCS affect the bone tissue that had been osseointegrated with the implant, the tissue that was intimately in contact with the implant. So to address this, we developed a new animal model that utilized a custom 3D printed titanium implant. As you see here in the image, was pressed fit into the proximal femur of Long Evans rats. And the implants were allowed to osseointegrate for a period of 6 weeks. And then we went in and we just said, okay, let's apply stimulation of minus 1.8 volts for 1 hour to half the animals, and the other just served as unstimulated controls. And then 1 week after that, we went in and we looked at the bone implant interface using scanning electron microscopy, as well as micro CT imaging. And so the results here showed that in the absence of infection, so it's important to say here that this work was done without the bacterial burden being present. So just stimulation alone was applied to an osseointegrated implant. It does not damage the host bone that is directly in contact with the implant. So that's important as well to understand that we're not causing damage to the host bone. And also, we know that the osseointegration is actually maintained following that stimulation because we looked a week later. Furthermore, after some preliminary analysis, we also believe that the electrical stimulation may actually be promoting new bone formation in the spaces adjacent to the implant, as shown by the red arrows in the diagrams here on the left, which are the SEM images, as well as the center micro CT cross-section. And we're particularly excited about this finding because this would kind of be a holy grail of sorts, in that the exact stimulation parameters that we've shown previously to be effective at treating infections may also be promoting new bone formation. So obviously there's a lot of work that needs to be done to confirm this, but we're excited about this. And just as I wrap up, just want to quickly introduce one new tool. This is a new live microbe imaging system that allows us to visualize what happens to bacteria in real time when the underlying surface is stimulated. So here's a quick video showing what happens when you apply minus 1.8 volts to that titanium, and you get a disruption of immersive biofilm. So what you see here is a top-down view of a hydrated immersive bacterial biofilm on a titanium substrate. And those darker regions correspond to regions of increased biofilm thickness. And the video is sped up, but what you'll see is that the stim is applied at about the 5-minute mark. So you see that almost immediately there is this disruption to the structure of the biofilm once the stimulation is applied. And this disruption is quite apparent when looking at pre and post stim images. Now, this is a relatively new tool in my lab, but we've begun to observe what happens at other stimulation magnitudes are applied. This is just a montage to kind of illustrate that there are effects of different magnitudes, and at different time points, they become effective. But what we're finding is that we can fundamentally disrupt the adherence of the biofilm and kill them, to reduce the viability by applying this stimulation. So just to conclude, although I have not been able to show all of the studies, our data indicates that the stimulation has antimicrobial properties that are magnitude dependent and time dependent, synergistic with traditional antibiotic therapy. It has effects against both gram-positive and gram-negative pathogens, and it's been effective for infection prevention and eradication. We believe that the electrochemical changes that are ongoing with this stimulation are at least a part of this antimicrobial mechanism, but we've developed some new tools and we're going to continue to provide new insight as we go forward. And as Dr. Campionieri mentioned, this truly has been an interdisciplinary team effort. And we've gotten the chance to work alongside all of these dedicated scientists and engineers at all levels of training. Thank our funding sources that have supported us for this work, and conclude by saying thank you, and would be happy to take any questions from the panel.
Well, thank you to all of our speakers. I can just say that the science that you have described is very hopeful, because anything to avoid that gruesome story that Dr. Boyle described would be really worth it. That looked awful in terms of having to deal with those infections. We have a number of questions in the chat, and we do have a few questions that were sent in advance. So I will just take the liberty of asking a couple of questions that had to do with the something that the MiniMed board is very interested in, which is the research that goes from the lab to the living room, or in this case, the operating room. So the questions are, how long does it take for a new technology to be introduced and actually get applied in the operating room? And a related question is, in developing these new technologies, what are the biggest obstacles that you face when you're developing a biomedical device? So timeline and biggest obstacle.
I can maybe take a stab at that in terms of the timeline. So I know from when Tony and I first talked to now, it's been over 10 years where we had to do the initial idea development. We were lucky to get awarded an idea development grant that did not require preliminary data. But then once you prove that out, then there's the patenting process, and then there's the regulatory process. And all of those, they're variable timelines depending on what type of device you're applying for. Are there previous devices that you can point to and say yours is similar to for regulatory approval? Do you have to go through a pre-market evaluation where you have to do rigorous, multi-year trials to prove safety and efficacy? And so I think there's a lot of variability there. But I think our timeline is somewhat typical, I would think, of the process. But we've also, the commercialization partner has been given the designation of a breakthrough device. So that opens up certain pathways through the FDA regulatory process to hopefully speed up that review, and you're working with the FDA closely on that. But I think, it takes quite a while. I know that's a vague answer.
One part. Yeah. So one of the issues is we work for a university, so the university has the right to the technology, and it's up to them to decide whether or not they want to advance forward with a patent. And that took some time because you have to do a search, like Mark said, to make sure there's nothing else out there, anything like this. And they usually get we got a provisional patent for 1 year, Mark, right?
That's right. Yep.
And then after 1 year, you have to make a call as to whether they want to spend the money and go for a full patent. And that took us a while to get a full patent. In fact, it was denied a couple times for, I believe it was Dr. Ahrensberger's own thesis that was being used against us in the beginning.
Right.
So it's really quite, and I've been involved in these many, many years, and it is a challenge to getting through that is one of the keys. And then you have to be able to do this in small animals and then eventually large animals. This is the first time I've ever been involved in one which actually was expedited somewhat through the FDA right now. And so I would say most of the time these things take 7 to 10 years for sure.
Yeah, certainly there'd be an incentive to expediting it based on what we heard about Dr. Boyle's description. There were a number of, and then the other question, well, you've already described some of the obstacles, I think, to going through this process. So there are a number of questions that are related to infection. Are there certain kinds of patients that are more prone to getting infection? If you have been treated for an infection, is it likely to recur? Are there any things that can be done if you're about to undergo surgery for a joint replacement that you can do to minimize your chances of developing an infection?
I'll tackle that one. I'll tackle let me answer those questions actually in the opposite order. So the second question was about, is there anything that patients can do before they go into surgery for a first time hip or knee replacement? So that's a little bit of a different animal than patients that have become infected, and then the questions that stem from that. So we'll tackle the first animal. There's lots of things that we have found out that can contribute to infection. It's not just one thing. We were all hoping for sort of a holy grail, that there was going to be the one thing that was going to contribute mostly to infection after total joints. But it's multifactorial. So most of the papers and the literature that's come out over the past couple of years have tried to focus on, the top couple things that contribute to infection, and mainly it all is revolved around two buckets. One is risk factors that can be optimized, meaning risk factors such as something like smoking. That is something that people can stop doing before surgery. So that's something that can be optimized or is modifiable. And then there is the non-modifiable risk factors, which are things like insulin-dependent diabetes type 1 that somebody had from when they were, a child. And although that may be modifiable, it's also something we can't really have that person not have diabetes anymore, or someone that has a congenital problem with their liver or their kidneys. That affects people's ability to recover after surgery, which could possibly predispose them to infection. So the major players are things like diabetes, smoking, wound problems. So people that have swelling in their lower legs or edema that can create ulcers or wounds. That is a huge issue, to the point where a lot of surgeons actually won't operate on people that have a lot of swelling in the legs due to many reasons before that they get that addressed. And then there's things like COPD, sleep apnea, which interestingly enough actually can affects the oxygen in the blood, which can predispose some people to infection. That's, again, the literature is at plus minus, but a history of cancer, active dental infections, dental problems, recurrent urinary tract infections that are difficult to treat, those can actually spread to joints. And then, heart failure, kidney disease, liver disease. Those are a lot, but those are kind of the big things that we look at and that I look at, my office looks at, and then we see, okay, what of those 10 things that I just mentioned can we make better before the surgery? And then what can't we? And what we can't make better, that's when I actually sit with my patients and I say, okay, you're 5% more at risk because you have this. Now you're 10% more because you also have this. And then we make the decision about whether to move forward with surgery or not. So that's question number one. Your question regarding infection after total joint replacements, and I think part of that question was, do they come back? And yes, they do come back. That's based on, again, a lot of things. One is the bacteria, the type of bacteria that's growing. For example, MRSA, which is a very strong virulent bacteria, has been shown to come back if we didn't take all the implants out and do an appropriate washout and everything. So that's kind of an organism that I get a little bit worried about when people have that. And then there's the other that I consider scary organisms, like, antibiotic resistant Enterococcus or something like that. So the more virulent organisms I worry about coming back, and I'm very hesitant about putting a real joint replacement back in somebody after an antibiotic spacer. I let that play out a little bit longer than I would somebody that has an organism that I talk to my ID docs and my microbiologists about, that is sensitive to every antibiotic that we have available and seems like it'll be something that'll be a little bit easier to treat. They also can come back, a different organism can come back. So that's a whole new level that we're exploring, which is what some of my research is trying to figure out why someone's infected with staph XYZ and now they're infected with Enterococcus a year later. So there's this whole complicated, I think, meshwork of why people become reinfected. But just to give you some hard numbers behind it, if someone has an infection, you do a 2-stage, which we talked about, which is taking everything out, antibiotic spacer, putting it back in, the success rate is about 75 to 80%, meaning that you're not going to go back to the operating room for a couple of years. So again, it's not great, but it's a better success rate than 50 or 40. But that's kind of where we are right now, is that we want to move that needle up to above 90% success rate.
So there was a question about a specific bacteria. Can blue light be used to kill Propionibacteria acnes?
So I guess that's a
I don't know who asked that, but maybe you do.
Wow, that's a great question. I'm doing a little bit of basic science. I was as a resident, and we're actually been applying for grants. We didn't get our first one, but hopefully we'll get the next one. But I was looking at, it's now called C. acnes, Cutibacterium acnes, and looking at whether blue light can treat infections with this. And in our very preliminary Petri dish science studies, yes, it can, but we're so far from knowing whether it's possible to treat, this particular bacteria. But great question.
And
So
this would be
blue light, I can tell you this, blue light's also been used on multiple organisms. And it can be effective depending on, the question is, can it kill biofilms as opposed to killing planktonic organisms? And that becomes a little bit more of a challenge. And an infection like this, I guess one of the issues that Mark and Keely both know is, how do you get it there, right? I mean, if it's an infected closed knee, you're gonna have to open it up to get the light there. It's still a good area because I work in, and I know Keely's doing some of this too. Photodynamic therapy is probably where they're getting that from. And that's pretty promising if you do it the right way. And I think the other part is, one of the neat things about this stim technology is if it was possible, could you stim the joint early on after, and again, I'll defer to Dr. Boyle here. I mean, I think the infections are usually, they come early on after surgery. Could you be stimming that joint while and promoting bone growth and keeping the organisms potentially off the implant prior to an infection? Would be an interesting area that I know that Mark and I are looking at.
Yeah, more of a preventative.
Yeah.
Again, where do these infections come from, right? That's another big area that we're kind of, I think we know, but I'm not really sure that we really do know. Now, I've only been in practice now, I don't know, 8, 9 months, but I saw a lot in my fellowship in New York City, and it's not always as straightforward as, it comes from the operating room and it kind of finds its place in the hip or the knee, and then it adheres itself to the implant, and then over time the burden becomes so high that person has pain. I don't think we want to think that's the case, but I don't know. But yeah, absolutely, the application of that technology in a preventative standpoint, as you mentioned, would be incredible to be able to do that.
And are there any best practices for wound care? I know we have a home care nurse in the audience. Are there any recommendations for wound care? Because certainly family members, patients, nursing staff at home are all involved in wound care. Can that contribute?
Yeah, absolutely. So from a primary total joint perspective, first time go around hip or knee, no problems. Wound care is very easy. For my patients, they all get absorbable sutures and a waterproof dressing. They can shower post-operative day 1, no problems. So I don't worry about much, I don't want them to go in the ocean or the pools and things like that for 6 weeks. Then you jump into the ball game of these infected patients. And that is a whole nother area. And yes, I certainly, for most of those patients, need help with wound care for their incisions. Then there's the realm of wound care for people that, for example, I have a patient who recently, a patient that was sent to me from Pennsylvania, who had a wound on their toe, a diabetic ulcer on their toe, that they could not, had been being treated for a long time. And then subsequently their knee became infected from the toe. So they were growing the same organism from the toe as they were from their knee when I took care of their knee. So wound care is a huge issue in my book, a huge whole field of medicine that's incredibly important to me. And recognizing the fact that wounds in certain areas, those bacteria get in the bloodstream and then they find their way to metal. And it is amazing what those bacteria can do and how they find their way to metal. And that's what I see actually pretty commonly. So again, to your point about the technology, is that what if someone had a wound and we knew that that's a huge source of possible infection? Could we turn on this, a system where we could kind of stimulate the implant for a while until we heal the wound up to prevent them from getting an infection? That would be amazing. So I don't know if that really answered your question directly, but.
Yes, I think you did answer it from 2 perspectives: the immediate wound and some secondary wounds that somebody has from another cause that could add to infection. But this has been such a wonderful presentation. We are really coming to the end of our hour or an hour and a half, and what we will do is we are going to post this presentation, which has been recorded, on the MiniMed website. There are a number of questions that unfortunately we couldn't get to, and we will scan those and try to get some answers that we could also post on the website, because we really want this, this is really a learning community, this MiniMed community. And so we want to continue to stimulate questions and provide as many answers as possible. So I want to thank Dr. Boyle, Dr. Campanari, Dr. Ahrensberger. We hope we have you back in a very short time frame when you could tell us about your first trials with humans in the OR. So thank you all, and we are really grateful, and we look forward to seeing you at a future MiniMed series.
Great, thanks for having us.
Good night.
Thank you. Take care, everybody.
Bye now.
Take care. Thank you.
Thank you.